Good morning, good afternoon, good evening, wherever you are. I am Dr. Rosario Gomez-de-Liaño from Madrid, Spain, and I am very honored to be asked and invited to share this webinar, which is organized by International Pediatric Strabismological Association Council and the Taiwanese Pediatric Ophthalmology and Strabismus Society, and hosted by the American Academy of Ophthalmology. First of all, I wanted to give the word to the president of IPOSC, Dr. Farouk Orge, that I think has some connection problems, and he was very attentive to send us a video in case he could not reach the webinar.
Dear friends, I would like to welcome you all to our next monthly International Pediatric Ophthalmology and Strabismus Council webinar, this time co-organized with Taiwan Pediatric Ophthalmology and Strabismus Society. The session will cover various aspects of paretic strabismus and strategies for management. This event is hosted by the American Academy of Ophthalmology and is endorsed by the Taiwan Academy of Ophthalmology and Taiwan Agency for the Prevention of Blindness. Without further ado, I would like to hand the session over to our fantastic moderators, Dr. Tsai and Dr. Gomez-de-Liaño. Thank you so much for being with us.
Next, I want to have an introduction of TPOSS. On behalf of TPOSS, I would like to thank IPOSC for providing us this opportunity to have a joint webinar on the topic paretic strabismus. TPOSS is short for Taiwan Pediatric Ophthalmology and Strabismus Society, which is composed of ophthalmologists specialized in the field of pediatric ophthalmology and strabismus in adults and children. TPOSS is a subgroup of Taiwan Academy of Ophthalmology, which is one of the major associations of ophthalmologists in Taiwan with near 2,000 members. We also would like to thank American Academy of Ophthalmology for providing the meeting platform and the endorsement of Taiwan Agency for the Prevention of Blindness. We wish the webinar great success and hope to welcome all friends around the world to visit Taiwan after the pandemic.
So let's begin the webinar, which is called A Conversation about Paretic Strabismus and Strategies for Management. The symposium is going to have 3 big blocks, one dedicated to the third nerve palsy, one to the fourth nerve palsy with the pearls in the diagnosis, and then to the sixth nerve palsy. As I said, I'm Dr. Gomez-de-Liaño from Madrid, Spain, and I'm very happy to share the moderation of the session with Dr. Chong-Bin Tsai from Taipei. Dr. Tsai, he is assistant professor in the Taiwan University. He works on the Chiayi Christian Hospital, and he has different positions in international and national organizations. He's on the Taiwanese Pediatric Ophthalmology and Strabismus Society, and he's a member of the Taiwan Academy of Ophthalmology, and he's also a council member of the International Strabismological Association. Our first speaker is going to be Dr. Gill Adams from the Moorfield Eye Institute. She's a consultant at that hospital in strabismus and neuro-ophthalmology, and she chaired also the Royal College of Ophthalmology and co-chaired the Royal College of Pediatric and Child Health for the ROP screening guideline group, and she's the vice president of the International Strabismological Association, and she will speak on the surgical management of the third nerve palsy. Then we will have Dr. An-Guor Wang from Taiwan, He is at the National Yang Ming Chiao Tung University in Taiwan. He works in the Veteran General Hospital in Taipei. He has also commitments in different international organizations as the Asia Pediatric Pacific Academy of Ophthalmology, at the ASEAN Neuro-Ophthalmology Society, and he's a counselor on the ASEAN Pacific Strabismus and Pediatric Ophthalmological Society. He will speak on the pearls and pitfalls in diagnosis of paretic strabismus. Then we will go on to Dr. Lin Hiu Yu, that she also works in Taiwan. She's professor at the China Medical University in Taiwan. She works on the China Medical University Hospital in Taiwan, where she is the chief of the Pediatric Ophthalmology Unit. She's professor of the School of the Chinese Medicine China Medical University in Taichung, Taiwan. And then she works in the Department of Molecular Genetics in the China Medical University Hospital in Taiwan. And she will speak on the effect of the modified graded recession and anteriorization and myectomy of the inferior oblique palsy, of the inferior oblique on superior oblique palsy. Then we will go to all the side of the world to Andrea Molinari from Ecuador. She's associate professor at the University Central of Ecuador. She's director of the fellowship program in pediatric ophthalmology and strabismus at the Fundación Metrofraternidad of the Hospital Metropolitano in Ecuador. She's a pediatric ophthalmologist at the Hospital Metropolitano in Ecuador. She's also the vice president of the International Strabismological Association, and she's past chair of IPOSC advisory board. And she will speak on when one muscle surgery is not enough in superior oblique palsy. And then we will go to the sixth nerve palsy. We are very happy to announce that we will have Anthony Murray from Cape Town, South Africa. He is an emeritus professor at the Department of Ophthalmology at the University of Cape Town. He was past president of the South African Society of Pediatric Ophthalmology of Strabismus, past president of the Ophthalmology Society of South Africa, and also vice president of the International Strabismological Association. He's a member of the advisory board of the International Pediatric Ophthalmology and Strabismus Council, and he will speak on some aspects of paretic and paralytic sixth nerve palsies. And then last but not least, we will have Tzu-Hsun Tsai from Taipei, Taiwan. She's associate professor of the National Taiwan University Hospital. She's chief of pediatric ophthalmology of strabismus section at the National Taiwan University Hospital, and she's chief of ophthalmology at the Department of the National Taiwan University Children's Hospital, and she will speak on the management of abducens sixth nerve palsy. So I'm going to share, and we will give the word to Dr. Gill Adams.
Hello, I'm Gill Adams, and I'm going to talk about the surgical management of third nerve palsy. The palsy may be partial or complete, and the classic one is the divergent hypotropic eye with a dilated pupil and no double vision because the eye is completely shut. But this may not be the case, and it may be partial with double vision. Importantly, you need to remember that the patient may have lost fusion, which means that even if you align these patients well, they may still have intractable diplopia. The aim of your treatment, which you don't start for a year after the onset in case there is spontaneous improvement, is to provide the patient with the largest possible area of useful single vision, which is usually in primary position and in down gaze. But occupationally, some patients may wish to have a larger field in up gaze, and you need to explore that before you start intervening. If the patient is likely to have intractable diplopia, you may wish to consider an occlusive contact lens which will solve the problem. Ptosis surgery should be done after any squint surgery. Most patients will have an isolated exotropia. Some will have an exotropia and a hypotropia. It's uncommon to have a vertical deviation alone, and you need, like in a sixth nerve palsy, to distinguish between a partial and a complete palsy, and botulinum toxin is a very useful trial for this. For a hypotropia with reasonable down gaze, I find a nap is better than an inferior rectus recession. And this is where you take the medial and lateral rectus up to the border of the superior rectus. And the original paper described an improvement of 38 prism diopters, which is larger than I would usually find. I find I get up to about 20, but you may get more, so be prepared for that. If you've got a hypertropia and poor inferior rectus function, I would suggest an inverse nap. If you have some inferior rectus function, you might want to consider resecting the inferior rectus. The papers described a 20 diopter improvement originally. Now I have to say I have achieved significantly more than that, so be careful you don't overcorrect, and don't put Farden sutures on, because that's a sure way to get an overcorrection. Classically, you have vertical deviation and your horizontal deviation, and you can combine treatment for that with horizontal surgery with a transposition upwards for a hypotropia, a transposition downwards for a hypertropia, and you will correct approximately 2 diopters of vertical deviation per millimeter of your transposition, and you continue to use your standard surgical horizontal surgical tables. A recess resect is good if you've got good ocular movements and little or no height. And as I say, if there is height, you can combine with a transposition. You can combine this with an addition of skin traction sutures for 4 to 6 weeks, which augments the result and stops it drifting backwards. The classic description was of non-absorbable sutures placed through the muscle insertions and taken out through the lids and tied over bolsters. I have to say nowadays I wouldn't use silk or ethibond, I would use Prolene. It reduces skin scarring. And this has been reported to be extremely effective. One nice little trick that you can consider is to operate on the good eye if there's aberrant regeneration, because that corrects both the divergence and the ptosis, and so the patient may avoid a further operation after you've done your procedure. It may, however, be a little bit of a sell to a patient that you want to operate on their good eye to correct their bad eye. But as I say, this is a good surgical tip to consider. If you've got complete lack of adduction, this is quite a surgical challenge, and the list here is of operations that have been considered and tried. And I have to say, when there's a list this long, you know that there isn't one operation that is your go-to operation. You know that some of these will work in your hands and some of them won't. What you have to do as a surgeon is to find out which works for you and keep using it and refining it. Superior oblique tenotomy works if the superior oblique is intact and overacting with an A pattern and in torsion, and it's useful for a hypotropic exotropic eye. I find it tends not to last, which is why it's not a procedure I use very often. Transposition, the classic description was fracturing the trochlea and moving the muscle. Nowadays, I think it's been shown you don't need to do that, and you can detach the superior oblique and move it downwards and nasally towards the medial rectus. It's said to be able to correct up to 20 diopters of height, and you would normally combine that with some horizontal procedure. Medial transposition of the superior and inferior rectus, commonly very similar to what you do but in the other direction to a sixth nerve palsy, needs to be combined with resections, usually of about 4 millimeters, I find, because the muscles have less effect as they're moved nasally. Don't use this as an operation if patients had any horizontal procedures done because of the risk of anterior segment ischemia. And I have to say, I have found that although you don't get height necessarily initially, it's not uncommon to find a patient getting a vertical drift, usually a hypertropia, sometime after your intervention. So it's not my go-to operation anymore. We are starting to hear a lot more about using the lateral rectus to pull the eye over, and you can use it as a whole muscle transposition. In this case, you're taking it with a hypotropia, you're taking it superiorly. With a hypertropia, you take it inferiorly. And that was the first description of the use of the lateral rectus to pull the eye into adduction by Dr. Taylor. More commonly nowadays, we use a split lateral rectus transposition where the lateral rectus is split for about 15 to 20 millimeters, and the two strips are then separated and they're passed under the superior and inferior rectus and attached to the sclera near the medial rectus border. Best combined with an inferior and a superior oblique tenotomy. Now I've had an overcorrection with this, but I've also had undercorrection, and I think it's fair to say that it is very, very difficult to reoperate because you'll find that the lateral rectus has become scleralized. Complications that have been reported include a significant risk of choroidal effusion and optic nerve edema, and as I say, it is not a procedure to undertake if the patient has had previous lateral rectus recession, because it's going to be too much of a stretch to get that lateral rectus passed under the relevant rectus muscles and round to the medial rectus muscle. You need a good assistant when doing it, and it's obviously you've got to move the globe to get it as near to the medial rectus as you possibly can. Globe fixation techniques have been used since the early 1990s, using different methodologies, starting with silicone tubes, fascia lata, and using bone flaps to fix to the periosteum. The technique that I prefer to use in this sort of situation is fixing both lateral rectus muscles to the wall. So I take the lateral rectus off and fix it to the soft tissue of the orbital wall, and with an orbital colleague, although you don't have to have an orbital colleague if you're happy doing DCR type procedures, you take a non-absorbable suture and place it in the medial wall periosteum and then tie it down. I place skin traction sutures with Proline through the limbus, through the lids, and tie them over bolsters for 5 to 6 weeks, and I found this a safe and effective method of treatment. We've had problems with one suture protruding, which needed to be trimmed down, and one immediate post-op corneal abrasion. This is a slide comparing that technique with the lateral rectus split technique, and you'll see that the lateral rectus split technique seems to have a is a more powerful procedure. I can't quite explain why it is, but it does seem to be when it goes well. So in summary, there are many operations that you can do for third nerve palsy. You have to choose the appropriate one for your patient, whether that is vertical, whether that is horizontal, whether it's a combination of the two. I think you need to be very realistic with the patient. It is not possible to restore completely normal motility. I think your aim has got to be to get the patient lined up in primary and to give them the best single field that you can. But so many of these patients have lost their fusion that you may well need to combine that with the use of an occlusive contact lens to rid the patient of diplopia. It's extremely important that you make the right management plan at the beginning because if you decide to do a recess-resect, and this is a complete third nerve palsy, it is unlikely that that procedure will work, and it then limits any further intervention you do because of the risk of anterior segment ischemia. So planning is extremely important in these operations. You need to know whether it's partial or complete, and then make a plan of what you can achieve, and you need to make sure that the patient understands what the limitations of your intervention are. But there is no doubt that with the right choice of operation, you can make a significant difference to your patient, to their quality of life, and how they function. So it's well worthwhile doing as well as you can. Thank you.
Thank you, Jill, for covering the so many aspects of the cerebral palsy. I have one quick question that for the transposition of superior oblique medially, do you need to resect the superior oblique tendon before transposition?
No, I don't. But I have to say I haven't found it a long-term effective procedure. I find that these procedures work for a few weeks, and then if you have longer-term follow-up, I found that it is not as effective.
We have questions from the audience. Because the time limit, I will only raise one question. Why do you do superior oblique tenotomy and inferior oblique myotomy with nasal transposition of superior LR?
It's said to help with improving the adduction effect of the muscles. Now, I know that Linda Daji, who's really popularized this operation, says that she needs to do that to get a 100% success in the operation. Now, I've done it without and had success, and I've done it with and failed. So I think anything that you can do to improve the adduction effect when you're faced with a essentially non-functioning medial rectus is good.
Thank you, Jill. Because we have a slight delay, so we will go forward to the next speaker. And the audience, if you have more questions, please press your question in the chat room. We will reply to them after the webinar.
Dear Chairman and my dear friends in Taiwan and the IPOSC, first I want to thank the Dr. Rosario Gomez and the Chong-Bin for inviting me to attend this symposium. And on behalf of the Taiwan colleagues, I also want to thank the IPOSC President, Dr. Farouk, and Dr. Jin, and also the past president, Dr. Sona Fasfandi, for organizing this wonderful Taiwan IPOSC symposium. And today I'm going to talk about the pearls and pitfalls in diagnosis of paretic strabismus. Because of the time limitation, today I'm going to focus on the vertical strabismus. I have no financial interest or relationship to disclose. I think the history taking is quite important, that discovering the recent events such as a trauma event, and also tracing the past medical history such as the myasthenia gravis would be important for differential diagnosis. Relieving or worsening factor for the symptoms might also help for the differential diagnosis as well. Usually, I will begin my eye examination from the external appearance. Unilateral ptosis or bilateral ptosis, or even the lid retraction may help for the differential diagnosis. extraocular movement is especially important in the paretic strabismus. And here is a model for the right eye. And if we found a limitation in the superior nasal direction, which may imply a IO palsy, and the limitation in superior lateral direction may imply a superior rectus palsy. Limitation in the inferior nasal direction may indicate a SO palsy, and the limitation in the inferior lateral direction may imply a inferior rectus palsy. In each of these directions, there are several commonly occurring diagnoses which may occur in this special direction. On the other hand, several systemic diseases such as myasthenia gravis or thyroid eye disease, they may involve individual rectus muscle and present as an individual rectus muscle palsy that will be different in each pattern. Bischofsky three-step test may help us to isolate or locate the paretic muscle in the vertical strabismus. Step 1 is to see which eye is higher, and step 2 is to see if this hypertropia getting worse on gaze right or left, and step 3 would be see this hypertropia getting worse on right tilt or left tilt. In this picture, you can see this young boy have a right hypertropia in primary position, which is getting worse on left gaze and also getting worse on right head tilt. And the three-step test indicate this will be a pattern of the right side SO palsy. And this is a typical finding in the congenital SO palsy. The vertical misalignment is quite large, and that would be the usually pattern for the congenital SO palsy. Maddox double rod test may help us to detect the subjective torsional state in each eye. I also use the fundus photography. I will extend two horizontal lines from the center of the disc and from the lower margin of the disc. If the fovea sits above the center line, which indicate there might be an intorsion in this eye. If the fovea is located below the lower margin of the disc, then that could indicate that there is an extorsion in this eye. Let's look at our case. Case 1 is a 72-year-old male patient, and he complained about diplopia after falling down from a motorcycle 2 days ago. From the external photography, we cannot see which eye is higher, and the prism cover test there shows there is a 6 prism diopter of left hypertropia, which is getting worse on the right gaze and also getting worse on the left head tilt, and it indicates that's a left side SO palsy. Fundus photography show there's a extorsion in the left hypertropic eye, and the Maddox double rod test show there's a 10 degree of extorsion in the left eye as well. So the clinical diagnosis would be the left side traumatic Forstner palsy. As you can see that the acquired Forstner palsy is commonly associated with a small amplitude of vertical misalignment, which is quite different from the congenital SO palsy. In congenital SO palsy, usually the vertical misalignment will be much larger. And also, the acquired Forstner palsy, the patient will usually complain about diplopia. On the other hand, in congenital SO palsy, the diplopia may be compensated by the head tilt. Case 2 is a 28-year-old male patient, and he complained about diplopia for 1 week. And from the external photo, you can see that there's a little bit right head tilt in this patient. And he also showed there's a left hypertropia in primary position, and the left hypertropia getting worse on the left gaze and also getting worse on the left head tilt. And it implies there might be a right IO palsy in this patient. However, the EOM did not show there is any limitation in the superior nasal direction in the right side. On the other hand, there is a mild limitation of infraduction in the left side. Fundus photography showed there is a intorsion in the left hypertropic eye. And the Maddox double rod test also showed there's a 10 degree of intorsion in the left eye. So the clinical diagnosis is right ocular tilt reaction with right head tilt, right hypertropia, which could be skew deviation associated with ocular torsion. MRI show there are areas of high signal change on T2 weighted image in the left side, middle and the inferior cerebellar peduncle. There is mild enhancement, and which indicate this could be a demyelinating process. So the differential diagnosis between the false nerve palsy and the skew deviation relies mainly on the torsional state of the eye. We can see that false nerve palsy is associated with extorsion in the hypertropic eye, while the skew deviation is associated with intorsion in the hypertropic eye. There is another test we call that upright supine test. We first measure the patient's vertical misalignment in upright position, then measure it again while the patient is in supine position. If there is a decrease of more than 50% in supine position, that would be a positive test. And you can see that false nerve palsy is associated with a negative upright supine test, and the skew deviation is associated with a positive upright supine test. Case 3 is a 53-year-old male patient, and he had diplopia for already 4 years. And you can see there's left hypertropia in primary position, which is getting worse on left gaze and also getting worse on the left head tilt. It also indicates there is a right IO palsy in this patient. Fundus photography show there's a mild intorsion in the right eye, which is compatible with a right IO palsy. Extraocular movement also show there's limitation in the superior nasal direction in the right eye. We did a force suction test, which is negative in this patient. And the blood test show there's a positive anti-acetylcholine receptor antibody. Chest CT show there's a soft tissue mass in the anterior mediastinum, compatible with thymoma. And we gave him mestinon treatment, and his symptom improved after the mestinon usage. However, the patient lost follow-up afterwards. We think in this patient would be a case of myasthenia gravis presented as an isolated right side IO palsy. Case 4 is a 39-year-old female patient, and she had vertical diplopia for 2 weeks, and she also had pain in the right trochlear region. EOM showed there is a limitation in the superior nasal direction in the right side. CT scan showed there is calcification over the right trochlear region, which may imply there is a chronic inflammation over this region. We decided to give him a local injection of Kenacort 10 mg over the right trochlear region. Her symptoms resolved after the steroid treatment. And also, you can see that her EOM improved after the steroid treatment as well. So we think she is a case of chronic trochleitis presented as a right side Brown syndrome. Differential diagnosis between the IO palsy and the Brown syndrome relies mainly on the force suction test, which is negative in the IO palsy and positive in the Brown syndrome. In addition, IO palsy is associated with SO overaction, which is quite rare in the Brown syndrome. IO palsy is characterized by the A pattern strabismus. On the other hand, Brown syndrome is characterized as B pattern strabismus. So, in summary, acquired false nerve palsy is commonly associated with a small vertical deviation with extorsion in the hypertropic eye and with a negative upright supine test. Skew deviation is associated with intorsion in the hypertropic eye and with a positive upright supine test. IO palsy is commonly associated with A pattern, SO overaction, and a negative force suction test. Brown syndrome is commonly associated with B pattern, rarely associated with SO overaction, and it is associated with a positive force-suction test. Thank you for your attention.
Thank you very much, Dr. An-Guor Wang, because it was really a very excellent presentation where you explain all the differentials in the vertical deviation, in which we always say that forenerve is the first, but those other issues have to be thought. I have just a brief question. Which is your experience on the upright supine test in order to differentiate between the forenerve and the skew deviation? Because neurologists don't use it, at least in our institution.
Actually, we still don't need to use this test because most of the condition can be solved by the torsional state. And under that kind of condition, we will go straight for the neuroimaging study and to find out the answer. So rarely do we use that. However, that's still a useful technique for us to evaluate between these two conditions. Once if the neuroimaging test is active, then you can try to use this kind of test to help for the differential diagnosis.
Okay, thank you, an excellent answer. And we are going to switch to the next presenter, which is going to be Dr. Hugh Lin, and she will speak on the effects of modified guided recession on the superior oblique palsy and myectomy.
Good morning and good evening, everyone. It's my honor to have a talk here. Today, my topic is effects of modified graded recession, anteriorization, and myectomy of inferior orbicle on superior orbital palsy. I'm Lin Huiru from Taiwan. Superior orbital muscle palsy is often the most frequently oculomotor abnormality in ophthalmic parties and is the most common etiology of abnormal head position in childhood. Superior orbital palsy often accompanied with head tilt to the contralateral non-paralytic side. The palsy is presented as either congenital or acquired. Sometimes congenital superior orbital palsy diagnosis after growth up as xenopia, and the diplopia cannot be compensated by abnormal head position. Most of the conditions are all recognized as idiopathic palsy. Superior orbital palsy can be unilateral or bilateral. The symptoms of superior orbital palsy include head tilt, vertical deviation, or ocular torsion. The ocular extorsion and the functional psychovergency of superior orbital palsy patient can be measured both subjective and objective. Subjective torsion measurement include double model examination or three-step test. Objective measurement methods include digital fundus, photograph of direct and indirect ophthalmoscopy. Surgical treatment of superior orbital palsy often can be accomplished by inferior orbital weaken, inferior myectomy, or inferior orbital graded recession, superior orbital muscle tug, or additional vertical rectus muscle, or Harada-Ita procedure. The most often operation done on superior orbital palsy patient was weakened or inferior orbital, and the most symptoms of superior orbital palsy will improve after inferior orbital myectomy or inferior orbital graded recession. In this report, we compare the effect and the symptom relief after the two operation methods in superior orbital palsy patient. This is a retrograde analysis include patients with unilateral or bilateral superior orbital palsy undergoing inferior orbital myectomy or graded recession anteriorization with or without horizontal rectal muscle surgery. The severity of superior orbital palsy was defined by the presence of characteristic superior orbital undulation, head tilt, and ocular torsion. Associated clinical factors examined include age at the time of surgery, present or absent of head tilt, vertical deviation, torsional angle, inferior orbital muscle overaction, superior orbital muscle undulation, documented by subjective scale. Grading severity of inferior optical vision secondary to superior optical palsy. The severity of superior optical under-Asian rating between 0 to +4 according to the up deviation of the pupil in adulttion. Score +1 to +4 range from 1 mm to 4 mm of deviation. The severity of superior optical under-Asian was rated in similar way as inferior optical Asian, as it was assessed when the patient was looking inferior nasally. Beside head tilt, fundus photographed, and the torsion angle were all documented. The torsion angle of ocular fundus was measured following the previous suggested method. The angle between a straight line, horizontal line passed through the optic center was automatically measured. Angle is the degree between the straight line passed through the optic disc, connect the macula and the reference line as normal fundus. Symmetric bilateral superior palsy, we do bilateral inferior optical myectomy, and unilateral or non-symmetric bilateral superior optical palsy, we do inferior optical graded recession and anteriorization. This is symmetric bilateral case, we do bilateral inferior optical myectomy, and this is unilateral case, we do unilateral inferior optical graded recession, and this is non-symmetric case, we do non-symmetric inferior optical graded recession and anteriorization. These are symmetric case, and these are non-symmetric case. Patients were categorized into 4 groups, and the inferior temporal position or attachment of the inferior optical muscle to the inferior lateral borders. Inferior optical was detached and reinsert a location along temporal border of inferior rectus. Patient was categorized into 4 groups based on the inferior temporal position of attachment of inferior optical muscle. According to the grade of superior optical palsy, anterior and the posterior border of inferior optical respective the inferior rectus lateral border as following: score +1 to +4, anterior border range from 7 to 2 mm, and the posterior border range from 2 to 0 mm. Anterior border of inferior optical is horizontal to inferior rectus insertion. Posterior border of inferior optical is lower and oblique to inferior rectus to avoid anti-elevative syndrome. Inferior optical muscle was flayed and faced inferior optical muscle near its insertion, and the anterior and the posterior border of inferior optical muscle were faced and arranged on arranged position with respect length to the lateral border of inferior rectus. As our surgical planning, myectomy was performed in 102 eyes, and the inferior optical graded recession was performed in 65 eyes. Head tilt, vertical deviation, and the torsional angle were all evidence decreased in all patients in all groups with no significant difference in the 2 operation methods. Using regression model to detect the torsional angle, variable significant affect net change of torsion after operation. Mean preoperative torsion angle was 16.3 degrees, which decreased to 5.3 degrees after surgery. The 2 inferior optical surgical procedures were with no significant difference in the effect. Horizontal rectal muscle surgery was concomitantly performed in 170 eyes, where no change the efficacy of both surgical procedures. According to the post-operative correction condition, the patient was divided into 2 groups. The resisted vertical deviation less than 4 present diopter and the cerebral amputation less than +2 were in full correction group, and the partial correction group were either one of these signs. The post-operation vertical deviation and the torsional change were all decreased, and there were no significant difference between these 2 groups. Both inferior optical myectomy and the graded recession have their different advancement. The strength of inferior optical myectomy was its simplicity, time-saving nature, and symmetric. However, in some studies, the end of the broken muscle while readhesion to sclera and result in recurrence of superior oblique palsy. Without grading and just using inferior oblique myectomy in all cases of superior oblique palsy, often induce post-operation reverse vertical deviation, especially combined horizontal esotropia retinal muscle operation. This might be due to high ratio of masked bilateral superior oblique palsy and the post-operation muscle, tendon, and wound syncytial. Inferior oblique recession anteriorization was better in unilateral and non-symmetric bilateral superior oblique palsy patient. However, the procedure was more challenging than myectomy and considered as a time-consuming operation. The amount of effect of inferior oblique recession anteriorization vary in different studies and often solely based on apparatus experience, which made standardization difficult. Our surgical planning for cataracts were used. These results were compatible with the previous study. In bilateral symmetric superior oblique palsy, inferior oblique myectomy method was a simple and effective method than graded recession. Bilateral inferior oblique graded recession in bilateral symmetric case was more compressed and might induce unexpected vertical deviation. This could be due to completely perfectly symmetric graded recession was difficult in both eyes. It cannot be overemphasized that the superior oblique tag or halata eta procedure were more effective in decreased subjective and objective extrusion as compatible with inferior oblique anterior transposition. Although inferior oblique myectomy or graded recession are also effective in improved ocular torsion. In a number of studies, single muscle surgery has been suggested inadequate for patients who present with large hypertrophy as higher than 50% after in primary case. In our study, the average amount of hypertrophy in both groups were around 80% after pre-operation, and the effect of the two methods in hypertrophy are all permanent. Previous report revealed that post-operative ocular torsion reduction may be temporary. It will begin a decline at 10 weeks after surgery. Our founder's photograph was taken 3 months after surgery, and the average following up period was 3.5 years. The torsion improvement of after operation is long-standing in our study, even we use 5G Tzu-Hsun absorbable suture. In case of combining horizontal retinal muscle, the post-operation results will not interfere each other, so surgery might not need to divide it into separated procedure. Conclusion: inferior oblique weakened procedure were effective and safe when treated superior oblique palsy. Symmetric bilateral superior oblique palsy was treated with bilateral inferior oblique myectomy, and unilateral or non-symmetric bilateral superior oblique palsy were treated with inferior oblique graded recession and anteriorization. Each procedure could achieve excellent and predictable results in objective ocular torsion, cycle deviation, and vertical deviation. Anterior border of inferior oblique is horizontal to inferior rectus insertion, and the posterior border of inferior oblique is lower and oblique respect to inferior rectus. This is important to avoid anti-elevating syndrome. Combined horizontal muscle in inferior oblique operation was safe and will not disturb each other. That's all my talk. Thank you for your attention.
Thank you very much, Dr. Lin. And because of the subject is quite close to the next one, I am going to call to Dr. Andrea Molinari, that she's going to speak on the title, When One Muscle Surgery is Not Enough in Superior Oblique Palsy, and then we will discuss both topics in both talks after this presentation.
Okay, thank you.
Very delighted to participate today in this webinar. Thank you for inviting me. And I'm going to talk on the treatment of superior oblique palsy, but I'm going to focus on those cases where one muscle surgery is not enough to get a satisfactory result. What makes superior oblique palsy treatment so fascinating is the huge variation in the different treatment possibilities. Superior oblique palsy has a profound effect on the innervational balance of the entire oculomotor system that can affect not only the cyclovertical muscles of the paralyzed eye, but also the ones on the sound eye. In most cases, this is followed by the overaction of the ipsilateral antagonist, the inferior oblique, and the patient will present a vertical deviation that is larger when looking up and to the opposite side. When this deviation is up to 18 prism diopters, an ipsilateral inferior oblique weakening procedure will be enough to solve the problem. In other more unusual cases, the muscle that is overacting is the contralateral inferior rectus. And in these cases, the patients will have larger deviation when looking to the opposite side and the lower field of gaze. And many cases, they don't have an ipsilateral inferior oblique overaction. In these cases, a contralateral inferior rectus recession will bring a satisfactory result, as in this case. In another clinical scenario, the overacting muscle is the ipsilateral superior rectus. And in these cases, the maximal deviation will be in all the upper fields of gaze, and the vertical deviation will be larger in abduction than in adduction. Sometimes also a restriction to the depression of the eye can be recognized. The Wilczewski head tilt test will be very positive. These cases will benefit of an ipsilateral superior rectus recession with good results, as you can see in this case. Less frequently and often in acquired cases, what is more noticeable is the underaction of the affected superior oblique. These cases might not present with a very large vertical deviation in primary position, but they might complain of a very bothersome torsional diplopia. The fundus photography might show excyclotorsion of the affected eye. These cases, a strengthening procedure, especially of the anterior fibers of the superior oblique, will be the trick and ameliorate the patient's symptom. But what happened when we have cases that have very large angles in primary position, 25 diopters or more, or patients that have a very lax tendon and show on top of the overaction of the inferior oblique and underaction of the superior oblique, or cases with very large excyclotorsion? These cases will not have a satisfactory result when operating on only one muscle. So the purpose of this talk will be to review these type of cases that need more than one muscle in order to get a good result. We're going to explain how to perform the clinical evaluation of these cases in order to plan for the most appropriate surgical strategy. So when do we need more than one muscle surgery in fourth nerve palsy patients? Well, in my experience, these are the three clinical scenarios where this is necessary. How we're going to evaluate these cases in order to plan for the most appropriate surgical correction? Well, we have to measure these patients in all gaze positions. Superior oblique traction test is mandatory, especially in congenital cases. Assessing the force ductions in the vertical recti is also important, and measurement of the excyclotorsion. Establishing the pattern of deviation by measuring in all 11 gaze positions is crucial in order to determine which muscles are the most appropriate to do the surgery. The surgeon has to match the field of gaze as a general rule and operate on the muscles whose actions are more effective in the position where the deviation is the largest one. For example, in this case, the patient had the maximum deviation in all the upper fields of gaze. And this is why both elevators of the right eye were recessed in order to obtain a good satisfactory result in all gaze positions, as you can see here. There are other cases also with a large vertical deviation in primary position, but where the deviation is largest or more noticeable when the patient looks at the opposite and lower fields of gaze. In these cases, the inferior oblique recession is combined with the contralateral inferior rectus recession and obtaining a good result, as you can see in this case. But not in all cases you will find an inferior oblique overaction, for example, like in this case, and the angle of deviation is pretty large in primary position. So in these cases, you have to choose for a different surgical strategy. In this particular case, many of these cases also don't show much torsion. In this particular case, an ipsilateral superior rectus recession combined with a contralateral inferior rectus recession was done, obtaining an acceptable result. The superior oblique traction test can be performed with different maneuvers, as you can see here. And it is very important to do in cases where the tendon of the superior oblique might be lax, especially those cases that on top of having important or significant inferior oblique overaction also show very noticeable superior oblique underaction, as in this case. And if we confirm that the superior oblique tendon is very lax, then a recession or a weakening of both inferior obliques will be better. The result will be much better if the strengthening procedure of the superior obliques is also done. Exploring the force ductions in vertical recti is also very important in order to determine if there is any contracture in one of these muscles. Look, for example, on this case that we have already seen, this lady on top of demonstrating a larger vertical deviation in all the upper fields of gaze also had a significant vertical deviation when looking down and to the same side of the affected eye. In these cases, if you do not assess the contracture of this superior rectus, you might think that the patient has a left superior oblique overaction, and you might be tempted to weaken this muscle, which will be a huge mistake because this patient will end not only with a right superior oblique palsy, but with a bilateral superior oblique palsies and will not be satisfied at all. Measurement of axial torsion is also very important, and this can be performed by different methods. The most common or popular objective method is by assessing fundus photography, and the most popular subjective method is by the double Maddox rod test. If doing this test, it is very important that to do it at least in primary position and in down gaze. With cases with large axial torsions like this case, you have to choose to do an intorting procedure. And the three most popular ones are the Harada Ito that might correct up to 10 degrees of axial torsion, but it is reported that the effect can diminish over time. Nasal transposition of the inferior rectus is a new described procedure to correct torsion, and it is reported to correct up to 7 degrees of axial torsion. Anterior nasal transposition is, in my opinion, one of the most powerful intorter procedures, but not much has been published regarding how much torsion it can correct. But in general, trying to correct, if you need to try to correct very large axial torsion, doing just one of these procedures might not be enough. At the last ISA Strabismus Forum, Dr. Miho Sato from Japan reported correcting up to 30 degrees of axial torsion by combining bilateral nasal transposition of the inferior recti together with bilateral inferior oblique myectomies. Let me end my presentation with discussing what I call the borderline cases. As you all know, and we have seen this in this first part of my talk, with patients with deviations up to 18 prism diopters can be easily corrected by operating on just one muscle. And patients with 25 or more diopters most certainly will need 2 muscle surgeries. But what about these patients with moderate angles in primary position? As you all know, one of the most unhappiest patients are the ones that get an overcorrection when operating for a 4th nerve palsy. So in these patients, the surgical strategy must be very careful. This year, our moderator, Dr. Rosario Gomez-de-Liaño, published a small series when treating these type of cases by inferior oblique recession associated to partial temporal inferior rectus recession. And I find this is a very smart strategy for these type of patients. So in conclusion, there are different situations in patients with 4th nerve palsy where more than one muscle must be operated on, and we have reviewed some of them. It is very important to do a very thorough examination of these patients, and the surgical plan has to be tailored to each patient according to the clinical findings. Thank you so much for your kind attention today.
Thank you very much, Dr. Yun Lin and Dr. Molinari, for this very extensive summary of the surgery on the 4th nerve palsy. And we are going first to go on the inferior oblique and then to the 2 muscle surgeries. So I have a question. First of all, is botulinum toxin has a role, or do you use it in your armamentary? That's the question on the chat that we received.
I did not do the Botox on the superior oblique palsy patient.
Okay. Then I have a question. You said, especially Andrea, that was matched very close to the Dr. Yulin numbers, that up to 18 diopters, one inferior oblique can work.
Yes.
I have 2 questions.
Yeah.
Is it the same a congenital superior oblique palsy, a surso-adductorial strabismus in which you have over elevation in a deduction, or an acquired traumatic case? Does it have the same effect? And second question, up to which amount of torsion are you going to indicate one inferior oblique?
It's more effective in congenital case because congenital case often have higher hyperdeviation the present diopter. So it's more effective than in congenital case. And in congenital case, we will do more advanced anterior realization. As for the excited torsion, we will correct about 50 degrees or about the excited torsion of the old patient. It's around 6 to 80 degrees, and the average is about 50 degrees.
Andrea, do you have any answer about the torsion? And I will add another factor. If your patient has a marked Bilchowski head tilt test, which is the muscle you think it corrects the most?
Well, regarding the torsional effect, I think that it's variable, and it will depend on the residual action that the paralyzed superior oblique still have. That's my experience. And regarding the Bilchowski head tilt test, if I have a patient with a very significant or positive head Bilchowski tilt test, I would think that he might have a superior rectus contracture, because in these cases, the head tilt test is more positive.
Okay, I thank you both very much, and we are going to go to the next sessions that they are going to be on the sixth nerve management. And the first speaker is going to be Dr. Anthony Murray, that we are delighted to hear him. And he will speak on some aspects of paretic and paralytic sixth nerve palsies.
Thank you, Rosario. And thank you to the International Pediatric Ophthalmology and Strabismus Council and to the Taiwanese Pediatric Ophthalmology and Strabismus Society for the invitation to participate. I'd like to speak on some aspects of abducens nerve palsies and paresis. It's critical that one differentiates between a total palsy and a partial paresis. In the study presented by Alan Scott and Stephen Kraft, they showed that normal patients can voluntarily rotate the eye fully into the field of gaze. Where the rotation is limited to 75%, that would be a -1 rotation, 50% -2, 25% -3, and to the midline, -4 if they can't get beyond it, or if they can't get to the midline, -5. This scheme is adapted by many people worldwide and is an agreement between different observers and on different occasions. It's important to assess the saccadic velocity of the lateral rectus muscle by including the fixing eye and getting a patient to move from full adduction into abduction. Where there is a total sixth nerve palsy, the saccade is a so-called floating saccade where the eye drifts out as the medial rectus relaxes. It is possible to measure the saccadic velocity on an EOG machine with an instantaneous printout where the normal velocity is between 200 and 320 degrees per second. In an incomplete paresis, it would be greater than 175 degrees per second, and with a complete palsy, 100 degrees per second. Very useful for following patients to see if they are improving. One has to perform a force duction test and a force generation test to assess the forces. We prefer to use topical anesthesia and local anesthesia. We put in anesthetic drops every minute for 5 minutes and then apply a cotton bud soaked in anesthetic agent to the area of the conjunctiva that we are going to fixate. And in that area, we inject local anesthetic. But while we are doing this with the patient lying down, we turn the syringe around and use the plunger of the syringe to touch the patient's forehead and ask them, do they feel it? And they will feel it. We then turn the syringe around, so we're going to introduce the needle. They can see the needle, but we do not touch the eye. We keep about 8 or 10 millimeters from the eye and ask them if they feel it. Clearly they don't, and they immediately relax, and it's much easier to proceed. So the vocal anesthesia is pretty important. In this setting, and this is a right sixth nerve palsy, the patient looks in the field of action of the lateral rectus, and we have injected in the 9 o'clock position. We hold the eye with tooth forceps in that situation and see if there's a mechanical restriction and whether we can move the eye an additional amount. Where the globe can be fully rotated, there's no contracture. But if we can rotate the globe from the midline to over 50% of full rotation, that would be a +1 contracture. +2, where they can't get up to 50% of full rotation, and +3 would be a maximal contracture. For the force generation test, it's imperative that the patient look in the field of action of the lateral rectus muscle, and we pull against any generated force. It's much easier to feel a subtle force where the patient is already attempting to abduct the eye. If one gets them to look into abduction, one can feel that force, and as they look straight or into abduction, the force diminishes. The force can be either poor when it's absent, or fair with significant reduction, or good where it's hardly reduced, but there is a learning curve. And the force too can be measured by using a strain gauge, as pointed out by Alan Scott, Carter Collins, and O'Meara, where the normal force is about 60 to 80 grams, paretic 15 to 60, and in a palsy it's less than 10 grams. Overall, the recovery rate is about 38 to 83%, the vascular being about 80%, and traumatic 6-nerve palsies, surprisingly, 83% recover, whereas the total palsies only 38 to 50% recover. Which will recover, we don't know, and the numbers that one believes depend very much on the study that one is quoting. The rate at which recovery can occur, we need to remember, can begin in the first 8 weeks when 37% recover. By 24 weeks, 6 months, 75% recover approximately, and by 52%, all have recovered. So in the acute stage, if one occludes the involved eye for diplopia, the patient tends to develop a medial rectus contracture. And for this reason, An-Guor and Jampolsky suggested that one should add a Fresnel prism base out as much as the patient would tolerate, probably 6 to 10 diopters, in front of the fixing eye. This causes the uninvolved left eye's medial rectus to contract into adduction, and by Hering's law of equal innervation, the non-functional lateral rectus of the involved eye is stimulated, and by Sherrington's law of reciprocal innervation, the medial rectus of the involved right eye it is then relaxed and a contracture does not occur. This patient then is wearing a patch over the involved right eye with a Fresnel prism over the left eye. Not all patients will accept the Fresnel prism, which blurs vision a little, and in this setting, one may consider hemiocclusion of the patient in the bottom picture's right eye, forcing her to fix in adduction. This has the same effect, but does not reduce the visual acuity, but does reduce the visual field significantly. In this setting, the occlusion in the first month gives one time to assess whether this is total or partial and whether it's likely to recover. But the use of botulinum toxin in the early stage is becoming more popular for justifiable reasons. It is imperative that one use a small dose of botulinum toxin so as not to paralyze adduction completely. This allows the patient to appreciate fusion in or close to the primary position so they function better with an improved quality of life. It reduces double vision in the head dome, and occlusion is not required, but if necessary, the involved eye can be occluded because contraction will not occur. We reported our early results of botulinum treatment for 6-nerve palsy along with a group from Moorfields and with Henry Metz and Malcolm Mazoff in the late 1980s. This patient has a right 6-nerve palsy with no abduction of the right eye, given botulinum toxin, and you'll see the deviation in the primary position is outwards, so he has an exodeviation with slight limitation of adduction, but with an abnormal head posture he can fuse, and in the long-term result, settled without any further procedures. In children, they may use an abnormal head posture to fuse, and if they lose the head posture, Botox may help avoid loss of binocularity, help to manage amblyopia, although general anesthetic is often required. One needs to remember that Botox can cause a vertical deviation, and injection in this setting should be given by somebody experienced in the technique. When it comes to the late management, if there is a good force, over 30 and up to about 40 grams, botulinum can be useful diagnostically and therapeutically. By reducing the contracture and increasing movement, it may help to determine the amount of lateral rectus function. If necessary, it allows one to delay surgery, and if appropriate, one can use lidocaine or lidocaine, which is short-acting instead of the botulinum, if one wants to operate soon after the test. This patient had bilateral total 6-nerve palsies following a severe head injury. She was unconscious, required a tracheostomy, and was intubated. After botulinum toxin injection to both medial rectus muscles with some myotosis on the left, you'll notice she's aligned with no abduction. But after 18 months post-operatively, you will see that she has a good range of movement in both eyes with full alignment and a full field. If the force is only a fair force of between 15 to 20 grams, one needs to remember before proceeding that recovery is rare after 6 months. But if there's any sign of recovery after 6 months, one must delay surgery until no further recovery is demonstrated. These cyclists are participating in a cycle race in which 36,000 people race on a 106-kilometer race in the Western Cape. And this is the largest race of this nature that is ticketed and timed in the world. This woman was a professional golfer, but a keen cyclist, and she was participating in the race and fell coming down a hill at high speed, had a head injury and a broken arm, and had a fair force of the lateral rectus 1 year later. In this setting, one needs to perform surgery, and what we did is performed an ipsilateral medial rectus recession, which is small, so it doesn't limit adduction, and an ipsilateral lateral rectus resection, which is large, as well as a contralateral medial rectus recession, so-called innovational surgery for the alignment. Here she is post-operatively, and she's straight in the primary position with very good abduction, but slight limitation of adduction. Now, is this a good result? Well, to evaluate the result of surgery in 6 nerve palsies, one needs to look at the goal of the surgery. One's attempting to improve abduction, to increase the field of binocular single vision, and to provide centration of that field of binocular single vision. And to do this, one needs to measure the field, most easily done on a Goldman perimeter, where the monocular fields are superimposed. And this is really the supreme court of judgment of the evaluation of any procedure for 6 nerve palsies. In this setting, you'll see that she has a large field of binocular single vision, which has some limitation of movement on right gaze. This is due to the fact that as a professional golfer, she had to turn her head to the right when on the backswing, and therefore wanted us to try to leave her with no diplopia on left gaze. So by using the field of binocular single vision, one can evaluate this, but also titrate the surgery to the patient's visual requirements. One of the problems is that the Goldman perimeter is used less frequently because it's been superseded by other devices. But the field of binocular single vision can be measured on a Hess chart or a tangent screen, or even on a Humphrey perimeter, where if one goes to the instruction section in chapter 13, it will instruct one on special mapping and how to do this manually. It can, of course, also be done on an arc perimeter, in this case, a handheld portable arc perimeter, which makes it very accurate. When it comes to late management, where there is a poor force of less than 10 grams, one should not perform an ipsilateral lateral rectus recess or resect because of the risk of anterior segment ischemia. And in this setting, before closing, I'd like to briefly just discuss 2 patients who were treated with botulinum toxin related to surgery. And the above patient had bilateral 6 nerve palsies with a large ESO deviation and no abduction. She was treated with botulinum toxin, which confirmed that she had poor abduction and a very poor force of both eyes. When the botulinum had worn off, however, you will see that the ESO deviation was less in the primary position. And at this stage, it was possible to perform a transposition which aligned her with abduction in both eyes with good field of binocular single vision and a happy patient. The second patient, in closing, is a patient who had a right-sided 6 nerve palsy. She was seen late, presented late, and had a post-operative transposition 13 months after the injury. You will see here she's aligned in the primary position, but has very little abduction of that eye. 1 week later, she was given botulinum toxin, and a month after the Botox, you will see that she has good abduction of the right eye with an exo deviation in the primary position, the desired post-operative position. After a year, she's well aligned with a full field of binocular single vision. So at the end of the day, when evaluating whether a palsy is total or partial, one needs to measure abduction, check the saccade, do a forced duction, forced generation test, manage diplopia and prevent contracture, And if there's only no or only partial long-term recovery, manage accordingly. I thank you for your attention.
Thank you, Anthony. Yes, because our next topic are also related to sex nerve palsy, and we will go forward to the next speech, and then we have a joint discussion after the next talk.
Hi, my name is Tzu-Hsun Tsai from National Taiwan University Hospital. It's an honor for me to be able to participate in this joint meeting. The topic I would like to talk about is management of abducens nerve palsy. I have no conflicts of interest to declare. I've divided my presentation into two parts. I'm going to start with MRI in the diagnosis of abducens nerve palsy, and then talk about the transposition surgery in the management of abducens nerve palsy. The sixth cranial nerve is the most frequently affected nerve in an isolated oculomotor palsy, and MRI is the imaging modality of choice in the evaluation of sixth nerve palsy because of its superior sensitivity in detecting intracranial lesions. These are causes of neuropathic strabismus in adults. Despite the advance of imaging tools, the cause of neuropathic strabismus in 20 to 30% of patients remained undetermined. Microvascular ischemic cranial nerve palsy is one of the most common causes of abducens nerve palsy in adults. It usually presents in older aged patients with underlying disease such as diabetes, hypertension, hypercholesterolemia, or coronary artery disease. With sudden onset horizontal diplopia, incomplete nerve palsy, and a gradual recovery over time. It was diagnosed by exclusion and still lack of Class 1 evidence to develop a consensus practice guideline. To date, the diagnostic algorithm proposed by Dr. Miller is still widely used. When encountering patients with abducens nerve palsy, patients of younger age, non-isolated nerve palsy, without risk of vasculopathy, or progressive or not improved presumed microvascular ischemic sixth nerve palsy are evaluated with MRI. The observation period is usually 3 to 6 months for microvascular ischemic cranial nerve palsy, and the cutoff age for the definition of young or old is 50 years old. Recently, increasing evidence proposed that neuroimaging procedure may have a role even in older age patients with isolated acute oculomotor nerve palsies, regardless of whether vascular risk factors are present. Around 10% of patients with presumed microvascular ischemic cranial nerve palsy had other causes by neuroimaging, and a structural lesion may be missed even in the most benign appearing clinical setting. A study reviewed the case series published from 2000 to 2015. In 889 cases of cranial nerve palsy, the neurologists were more likely to perform MRI scanning in every patient present with oculocranial nerve palsy. Meanwhile, ophthalmologists were more likely to determine risk factors associated with the abducens nerve palsy and then decide whether or not to perform neurological imaging. Why not scan every patient with sixth nerve palsy? First of all, MRI is a costly management practice. Secondly, MRI is not without medical risk and also has the potential for the discovery of the incidental lomas, presenting further costs to the healthcare system. Last but not least, imaging of the cranial nerve presents a challenge due to its small size and coarse. Let's take a look at the abducens nerve. The nerve emerges from the ventral surface of the pontomedullary junction and transverses the subarachnoid space, ascending the bony ramp of the clevus. The cranial nerve pierces the dura and proceeds into the medial petrous bone. It then enters the cavernous sinus, then passes through the superior orbital fissure to enter the orbit. Abducens nerve innervates the ipsilateral medial aspect of the lateral rectus muscle 1/3 of the way along its length. What is the ideal MI protocol for different segments of the abducens nerve? The nuclear and the fascicular segments is difficult to be identified in adult brains. Cisternal and dural cave segment is best revealed by high-resolution SSFP sequences with a heavily T2-weighted appearance, for example 3D-Seas and the analog 3D Fiesta. The interdural segments and within the skull-base foraminal are best seen with the techniques that allow enhancement of the surrounding venous blood, such as contrast-enhanced MRA or contrast-enhanced SSFP sequences. Within the extraforaminal segments, the sixth nerve adjoin vascular structure, fat, muscle, and/or bone as they pass through the head and neck, and may be visualized with a variety of techniques with SSFP sequence. Here are some examples of the MR imaging of the sixth nerve. This is a sagittal CC pre-contrast image show that the cisternal segment of the nerve. These are interdural and the foramental segments after contrast enhancement. Note that the visualization of the cranial nerves in the cavernous sinus is based on venous enhancement and can be only seen after contrast administration. Another clue we can look into the MR imaging of the sixth nerve palsy is the atrophic change of the lateral rectus muscle. The innervation atrophy of extraocular muscle is important evidence of neuropathic strabismus. Work with Dr. Dimmer during my fellowship, and we published the research investigating the high-resolution MRI in the diagnosis of neuropathic strabismus. In the study, we found 70% of the presumed idiopathic neuropathic strabismus has structural abnormalities. With Fiesta sequence, we found neurovascular compression in the cisternal segments of the cranial nerves. These are case presentation of patients we had their abducens nerve contact by basilar artery and caused clinical significant abducens nerve palsy. To sum up, we suggested the MI protocol as below. The 3T machine produces better imaging quality, but it is more expensive. 1.5T is acceptable for clinical use. The vessel size of 0.6 to 0.8 mm and should cover the entirety of the posterior fossa, skull base, and upper face, and use CIS or Fiesta sequence. 3D accretion if available. Use contrast enhancement if there is no contraindication. The second topic is transposition surgery for sixth nerve palsy. Vertical rectus muscle transposition was first described by Humanhai in 1907 for complete sixth nerve palsy. Its advantages include increase the area of binocular vision, shift the binocular field toward the palsy's gaze, avoid limitation of full adduction of the eye. Various forms of medication were proposed subsequently. It can be augmented by posterior fixation or loop myopathy, resection of the transposed muscle, recession or Botox injection of the ipsilateral medial rectus muscle. The Humanhai procedure transposes partial tendon of both superior and inferior rectus muscle to the superior and the inferior edge of a lateral rectus muscle. Posterior fixation or loop myopathy strengthens the transposed muscle by placing suture 8 to 12 mm from the insertion of the lateral rectus muscle with non-absorbable sutures. Various approaches to VRT have been proposed. Full tendon VRT with adjustable suture, Jensen rectus muscle union, and with muscle resection. Complications of VRT include scleral perforation, granuloma formation, the secondary vertical deviation, new torsion, and anterior segment ischemia. Vertical deviation was reported to be from 0 to 30% following the surgeries. Hypertropia is more prevalent in the secondary vertical deviation, and the unique anatomy of the inferior rectus muscle may contribute to this formation. The contracture of the scarring around the capsular palpebral head and the ligament around the inferior rectus muscle may be the cause of the hypertrophy. To avoid the development of vertical deviation and anterior ischemia, single VRT with superior rectus muscle transposition was proposed in 2006. Superior rectus muscle transposition with loop myopathy plus adjustable medial rectus muscle resection can correct a mean angle of 36% diopter of esotropia. In 2017, Dr. Wallace described inferior rectus muscle transposition in patients with abducens palsy with preoperative hypertrophy or intorsion. Surgical strategy can be determined by ocular motility pattern. In Duane syndrome with esotropia, inferior rectus muscle transposition was suggested for B-pattern strabismus, and the superior rectus muscle transposition was suggested for A-pattern or no-pattern strabismus. And how about 1.5 VRT? I'm going to present two cases. The first one is a 49-year-old female who had traumatic sixth nerve palsy in the right eye. Preoperatively, the right esotropia measured around 80% diopters. The preoperative photograph showed a profound esotropia. The right eye had limited abduction and could not reach midline. After receiving right medial rectus muscle recession and the superior and half inferior rectus muscle transposition, the patient was orthotropic without diplopia and with only about -1 abduction in the right eye. The second case was a 58-year-old female who also suffered from traumatic sixth nerve palsy. The left esotropia was measured 45 to 50% diopters. The strabismus was not improved with botulinum injection. She received left medial rectus muscle recession and 1.5 VRT. The double vision and the cosmetic appearance improved post-operatively. The effect of various VRT differs with the numbers of muscles involved, full or partial tendon transpose, and the combination of various modifications. In conclusion, transposition surgery is the management of choice for complete sixth nerve palsies. The effect of esotropia correction generally increased with number of transposed muscle, the addition of posterior fixation or loop myopathy, addition of recession or botulinum injection in the medial rectus muscle, resection of the transposed muscle. Which combination to be performed in the transposition surgery? It depends on the degree of esotropia and level of abduction limitation, risk of anterior ischemia, for example, age and underlying disease, preoperative vertical deviation and torsion, and finally, surgeon's preference. I appreciate the time you took to listen to my presentation. Thank you very much.
Thank you, Tzu-Hsun, for the wonderful talk. Okay, now we have a short discussion of the last two topics. First, I want to raise a question from our audience. That's a question for Dr. Murray. What did you think about Nishida procedure in sixth nerve palsy and when?
Thank you for the question. There have been many advances in the surgical management of sixth nerve palsies, and the transposition of the vertical rectus muscles without disinsertion has made a very big difference. It's made the procedures easier, less complications, and with the Nishida, it really does make it an option that one can use if there has been previous rectus muscle surgery inadvertently, and the risk of anterior segment ischemia is high. So it's an easier procedure to perform, and there is a similar procedure proposed by Marcon of Italy, where the superior and inferior rectus muscles are joined underneath the lateral rectus. Both of these are procedures that need to be reviewed. I have one concern about them, and that is that they are usually combined with the recession of the medial rectus, which leads to a limitation of adduction in the postoperative period. And in the reports that I've seen frequently, in the reports from Europe by Dr. Marcon, and one I think which Rosario was involved in, they report on the change in the ability to abduct the eye and the increase in the movement of the eye. But my concern is the limitation of adduction that occurs after these procedures. But I think that the long-term evaluation is important, and they've certainly made a major difference. There is some concern about the Marcon procedure. I think question from Turkey is the suture under the lateral rectus, that if that's a non-absorbable suture, can that lead to scleral problems in the long term with perforation? I think Rosario Gomez has had considerable experience for several years with that procedure. And to my knowledge, she's not had any case where the nylon suture has eroded through the sclera. I'm not sure if you care to comment, Rosario.
Well, in fact, the first technique was over the muscle, which impedes this problem. I didn't have any problem with it of eroding on the sclera, but you are the panel to speak about it. Chong-Bin, if we have the time to ask to the whole panel, one word, which is their favorite transposition technique on a patient without anterior risk of ischemia, which will they select it? Very quick.
For a complete sixth-nerve palsy?
Yep.
For me, Nishida now.
Jill?
Everyone can answer the question. I like Nishida procedure.
I'm moving towards an Nishida, but I think actually you need a good assistant. It's not quite as quick as you think.
Okay.
We need to mute the microphone if we are not speaking. Okay, and what about the others' opinion about your favorite procedure for sixth-nerve palsy?
For myself, I would prefer the Marcon suture.
Any more questions, Chong-Bin? Because Dr. Xiu Yulin did a really excellent presentation, and she focused also very much on the MRI examination. And which is your protocol? You scan now all your patients or only some of them? You did a beautiful examination on the Tzu-Hsun Tsai, on the yes, I'm sorry, on the evaluation of the sixth-nerve palsy. Yeah, Tzu-Hsun.
Yes. Because the insurance system, actually we cannot scan every patient so far, but we have very close observed this patient with presumed ischemic neuropathies. And in my suggestions, if you want to do it, and you have to do it in very detailed examination because the nerve is very difficult to scan. So I suggest this protocol, so maybe it will be very clear to see the nerve and to find the lesion.
Yes, I think we were. So I thank you very much, Dr. Tzu-Hsun, because it was really extremely well explained and full of details for our doctors to evaluate those patients and how and when and how, because it was really an outstanding presentation. So I think we have to close the session. First of all, I would like to thank the IPOSC organization and the Taiwanese Society of Pediatric Ophthalmology and Strabismus for allowing us to do this webinar. Secondly, really, and thank you very much to all the panel for those excellent talks, being on time and so clear, that give us a webinar that, as it's going to be recorded, can be again being watched. Also to my co-moderator, Dr. Chong-Bin Tsai, and all the participants that were here today on a Sunday in this moment of the year. And I just have to give the word to Dr. Tzu-Hsun Tsai, that he is going to be to close up and speak us of the future webinars of IPOSC.
Thank you so much. I'm Jason Yan from Hong Kong, and on behalf of the IPOSC Education Committee, I would like to thank Rosario and Chong-Bin for organizing and moderating such a wonderful webinar, and all our amazing speakers for such an informative talk and very insightful tips for handling the paralytic strabismus. So I would like to invite all our audience to mark the calendar for our next talk, our next monthly webinar. This time is with our Russia colleague in the IPOSC AOS webinar, which is the Association for Ophthalmology and Strabismus in Russia. And this time will be on restrictive strabismus. It is another Sunday, August the 7th. The same time as of today is 8 a.m. EDD time. And again, we have another panel, wonderful panel. So first, the moderator will be our IPOSC president, Dr. Farouk Ogay, and also from the AOS, from Russia colleague, Dr. Saiti Agagayan. And also for the speaker, we have Dr. Sayan Oskan from Turkey, how to manage the restriction related to strabismus surgery. Dr. Sukova Olga from Russia on the Duran syndrome, clinical cause, option, and treatment. And Dr. Balasayan Victoria on new technologies in the surgical treatment of Duran syndrome. And Dr. Tamara Raskinsky JV from Israel on recessions in the thyroid eye disease. Dr. Popoya Natalia from Russia, the so-varied Brown syndrome, and also Dr. Farouk Ogay on glaucoma surgery related restrictive strabismus. So I'm very sure this will be another very amazing webinar, and I hope you all will join it for a very fruitful discussion. Thank you all. So we will finish this session today. Thank you.